Good afternoon, everyone. This is Cha or Halo speaking on behalf of UP-Med Class 94 webinar team. This is an initiative of the University of the Philippines Medical Alumni Society. The UP-Med webinar series is held every Wednesday from 12 noon to 1 p.m. Manila time. It delves on important, current, and emerging medical topics and is targeted for physicians, especially general practitioners, occupational and industrial health doctors, primary care physicians, family and community medicine physicians, and other health workers. Registration is free. This webinar runs through the UP Manila Livestream platform at livestream.upm.edu.ph. If you have difficulties in accessing the webinar through the Livestream page, please watch the Facebook Live video on our Facebook page. This session will run for an hour with 30 minutes allotted per lecture, followed by a question and answer portion, which will be moderated by Dr. Alexander Tan. To participate in the webinar, please use the Q&A box found on the Livestream page or by texting your questions to 0915-259-9686. For Facebook Live participants, please type your questions in the comments box. May we now call on our moderator, Dr. Alexander Tan, who is a member of the celebrating class of UPCM 1994 and is an associate professor of the PGH Department of Ophthalmology and Visual Sciences.
Thank you, Charisse. Our time now in Manila is 11:58 a.m. and I'm speaking from the video conferencing room of the UP Manila IMS, Padre Faura Street, Ermita, Manila. Welcome to all our participants. Today's webinar is entitled All About the Big C, Cancer Screening, Early Detection, and Updates. The objectives of today's webinar are 1. To analyze the approach to rational screening and early detection for common cancers. 2. To describe strategies for preventing cancer. 3. To discuss updates on biomarker testing for cancer. And 4th, to give an overview of new treatment options for common cancers. Today's speaker is Dr. Dennis Lee Sacdalan. Dr. Sacdalan is a graduate of the UP College of Medicine class of 1998 and took his residency training in internal medicine at the UP-PGH and post-residency fellowship in medical oncology also at UP-PGH section of medical oncology. He is one of the first graduates of the Master of Clinical Medicine in Medical Oncology from UPCM, which he took while he was doing his fellowship training. He didn't stop there, and he is currently a PhD candidate in molecular biology and biotechnology from the National Institute of Molecular Biology and Biotechnology, UP Diliman. He is currently a member of the Philippine Subspecialty Board of Medical Oncology and is a clinical associate professor of the College of Medicine, Department of Medicine section of Medical Oncology. May we now call on Dr. Dennis Sacdalan.
Good afternoon, everyone, and thank you for inviting me to talk again in this webinar. It's quite timely that we will be talking about the Big C just 2 days after World Cancer Day, a day wherein cancer awareness is promoted. So before we proceed, here are my disclosures. Talked about objectives. As far as cancer specialists are concerned, we live in exciting times because of the cancer bill that has been passed by Congress and is awaiting the signature of the President to become law. The National Integrated Cancer Control Act provides for cancer control policies and programs that will ensure improved prevention, better screening, early detection, accurate diagnosis, and optimal treatment of cancer until the patient dies while receiving adequate palliative care or until he or she is cured of disease and called a survivor. This bill was passed by the Senate and the lower house late last year upon prodding by the Cancer Coalition of the Philippines, which is composed of patient support organizations, healthcare providers, and cancer advocates. This group worked with policymakers to create a law that would provide a more comprehensive care plan that the government would provide for cancer patients. If you look into the cancer control continuum, the bill actually covers every step of the cancer patient's journey, from early disease to advanced stages, from curative cases until the end of life, or if we were to be more optimistic, until even beyond survivorship. So that means with the Cancer Control Act, government will be providing measures for primary prevention to secondary, tertiary, and finally quaternary prevention. The cancer bill was passed because of the burden of cancer on society. And to get a better perspective of the problem of cancer in our country, let's first take into consideration the global burden of cancer. Globally, cancer ranks as one of the leading causes of morbidity and mortality, second only to cardiovascular disease. GloboCan, the largest consortium of tumor registries from different countries, estimated that there were more than 14 million new cases in 2012. Now, among the 14 million cancer patients, it is believed that there were around 8.2 million deaths due to cancer in 2012. And I believe the figures are rising at this time. 8.2 million deaths is about 15% of all causes of death. But if you think about it, that means 8 out of 14 million, or around 57% of those who are diagnosed to have cancer will eventually die. Furthermore, WHO reports that cancer deaths surpass the number of deaths due to AIDS, TB, and malaria combined. And what is interesting to note is that 57% or 8 million of new cancer cases and around 66% or 5 million of cancer deaths happen in developing countries. Asia has been identified as the site where almost half of all new cancer cases and slightly more than half of all cancer deaths occur. Why is there a disparity between the higher number of deaths in Asia compared to more developed countries? Aside from the fact that there are more people living in Asia, there is evidence to suggest that social determinants are at play all along the cancer control continuum. What has been found in several papers is that mortality due to cancer is not only a function of tumor biology and its treatment. Even within the same region, countries with high cancer mortality data, such as those in Southeast Asia and South and Central Asia, have been noted to have lack or absence of effective screening methods or screening programs compared to other parts of the continent. Other studies have found that higher morbidity or mortality is seen in families with lower family income or poorer work conditions, or even discrimination in the sense that some certain sectors of society seem to enjoy more healthcare benefits compared to others. So now we see a different dimension of cancer involving the role of society and even government in management. So given this reality, they say that cancer is a burden not only due to its health impact, but also because of its effect on the world economy. The global economic cost of cancer treatment was estimated in 2010 to be around 1.16 trillion US dollars. So this figure is probably higher by now. And the WHO considers cancer as an imminent human disaster due to lifestyle factors and aging, since people are now living longer enough to develop cancer. Now, what about the Philippines? Let's look at local data. The latest census in 2015 estimates our population to be less than 101 million. It has been estimated that around 109,000 individuals were afflicted with cancer in 2015. And among these, around 66,000 or 60.5% were killed by cancer in the same year, a figure that is marginally higher than world estimates in terms of percentage. What is alarming is when we look at the age demographics. We note that cancer incidence and mortality are highest in the age bracket of those 15 to 64 years old. And this represents the working age bracket. Cancer significantly affects a large chunk of our country's workforce and therefore has economic implications. Work gets disrupted for a good number of patients, and then a huge amount of government's resources are funneled to care for these patients. So now you get a better idea of cancer as not only a medical problem, but also a public health problem. Let's look at the top 10 cancers afflicting Filipinos. Topping the list of new cases for both sexes are breast, lung, and colorectal cancers. You see the rest there, the chart. And for the top 10 causes of cancer deaths for both sexes, at the top of the list are lung, liver, and colorectal cancers. Given these figures, what can we do? Based on findings, we've learned that one-third of cancers can actually be prevented through primary prevention or elimination or reduction of exposures to certain risk factors. Examples are smoking cessation, diet modifications, improving the level of physical activity or exercise, etc. As for the two-thirds that cannot be prevented simply by primary prevention methods, what can we do? We may not be able to identify risk factors for these cancers, but the best thing we can do is to try to detect them as early as possible with the hope of starting treatment earlier when disease extent is less and prognosis is better. This is where cancer screening comes in, because around half of cancers can actually be cured if intervention is started much earlier. So let's focus now on secondary prevention, which is equivalent to cancer screening. Secondary prevention is part of the cancer control continuum, and its goal is to reduce cancer-related mortality. Let me just point out that this is different from improving survival. If you chance upon some journal articles on new cancer treatments such as modern chemotherapy or targeted therapies, prolonging survival is one of the major endpoints of clinical trials. Improving survival is really more focused on helping stage 4 cancer patients live longer. But eventually, the cancer progresses, and these patients eventually still die due to their cancer. When we talk about reduction in cancer-related deaths, what we really mean is that we want to treat cancer early so that if the patients die, they die not from cancer, but from other causes, such as other non-communicable diseases, infections, trauma, etc. Now, when we talk about screening, we need to bear in mind a few issues. Two of these are the false positives and overdiagnosis. False positives entail additional procedures to confirm a positive screening test. So, for example, when a test turns positive, what would logically follow is a biopsy in order to confirm the diagnosis of cancer. But the biopsy has its own inherent risks since it is invasive. And doing it on a patient who does not really have cancer, but just so happen to have a positive screening result, can be potentially problematic. The second risk for harm would be overdiagnosis. Just like in prostate cancer, some cancers may be very indolent in their course, that they do not actually need to be treated at all because they may either resolve or regress spontaneously. Or another example is a pre-malignant lesion that may not progress to cancer. Aside from these two mentioned, other potential risks for harm include exposure to radiation during imaging and discomfort or anxiety due to the results. So a shared medical decision-making needs to be made between the physician and the patient whenever screening is discussed. And this involves not only relaying information to the patient, but also considering the patient's values and preferences before coming up with a plan based on the recommendations or guidelines that are acceptable also to the patient. So studies have been made to determine which tests can really contribute to reducing cancer mortality with minimal risks of harm. And that is how we have come up with recommendations for screening for some cancers. Let's focus now on 3 common and very screenable cancers. In the interest of time, I'll be presenting summary recommendations for each cancer screening measure and highlight a few things. In the question and answer portion, I would welcome questions if you want to know more or a few more details about these recommendations. So we'll start off with breast cancer. An age-related approach is usually followed when screening for breast cancer in women at average risk. Just to let you know, there is less than around 15% lifetime risk of developing breast cancer for an average woman coming from the general population. The age-related approach is followed because age is an important risk factor, meaning the risk of developing cancer is higher as you grow older. 69 with a reduction in mortality by as high as 20%. There is no evidence of benefit in screening women younger than 40 years old. So we usually advise patients to start annual mammography starting at age 40. Although there is really no consensus on screening between ages 40 to 49 years of age. The U.S. Preventive Services Task Force recommends starting screening at age 50, while the American Cancer Society qualifies things by saying you should start at age 45, but for women between 40 to 44 years, you may opt to start screening depending on the individual risk factors. The American Cancer Society also states that once a woman reaches 55, a biennial, meaning every 2 years, of mammography may be considered, but you may still stick to annual and continue doing it for as long as the patient has good health with a life expectancy of 10 years or more. Monthly breast self-examination, or DSE, and clinical breast exam by a healthcare worker are inexpensive and non-invasive. However, the evidence supporting the effectiveness of these two techniques in reducing cancer mortality is controversial. So in the US, they are not recommended. However, in our setting, we still advise it since some studies support combining these methods with mammo to enhance screening sensitivity, particularly in younger women in whom mammography may be less effective and in women who do mammography every other year. Let's move on now to colorectal cancer. Several tests are recommended for individuals with average risk, including FOBT, or the fecal occult blood test, FIT, or the fecal immunochemical test, stool DNA tests, flexible sigmoidoscopy, and colonoscopy. Now, the gold standard is really colonoscopy because it has the advantage of direct visualization of the entire colon and prompt removal of precancerous polyps or early cancers. It has been shown to reduce deaths from colorectal cancer by as much as 30 to 40%. Some disadvantages, though, are the cost and the tedious colon prep that the patient has to endure to make the test more sensitive. If the results are negative for cancer, colonoscopy can be repeated every 5 to 10 years, so it's not that frequent. An alternative to colonoscopy are the stool exams, which come in different types. The classic FOBT detects the presence of microscopic amounts of blood from polyps or cancers that get mixed with fecal material. The problem with this is that false positives may occur if a person eats meat or takes iron supplements because heme from animal food sources and iron are picked up by the reagent used. Also, if the polyp does not bleed, then no blood will be detected, resulting in a false negative result. Therefore, FOBT is usually done by advising patients to abstain from meat or iron supplements and to submit 3 different specimens of stool in order to increase the sensitivity of the test. FIT is more sensitive than FOBT because it detects human globin in the stools and not animal blood that you might ingest with food. Stool DNA has also been developed to identify tumor DNA shed off as fecal material as the fecal material brushes over an intraluminal tumor. Unlike FOB, there is no more need for abstinence or submission of several samples with these tests. These stool exams, when used, need to be done annually. Regardless of test use, screening for colorectal cancer is recommended to start at age 45 in average risk patients. It used to be 50, but now it's down to 45 based on international guidelines. Now, moving to cervical cancer, screening has been classically recommended by way of the Pap Smear, where a swab of the cervix is examined by a pathologist and assessed for any atypical cells. Evidence shows that regular screening decreases cancer incidence and mortality by at least 80%. Benefits are best seen when screening starts at 21 years of age or younger if there is history of sexual contact before that age. Based on SGOP, or the Society of Gynecologic Oncologists of the Philippines, they have their own guidelines now. Screening should start 3 years after onset of sexual activity. A Pap smear is then done annually. Then then, at or after age 30, after 3 consecutive normal smears, you may decrease the screening interval to every 2 to 3 years. Screening may be discontinued at age 70 or more in a patient who has an intact cervix if she has a history of more than 3 consecutive normal smears and no history of abnormal cytology. Screening for cervical cancer with HPV DNA test is another screening method used to detect high-grade cervical dysplasia, a precursor for cervical cancer. This makes use of cells taken from a cervical swab, the same one done during Pap Smear, and subjecting the cells to assays to determine the presence of HPV DNA. Trials show that HPV testing was superior to other strategies for preventing mortality from cervical cancer. And this can be done in tertiary hospitals with molecular diagnostic capabilities. In low to middle income countries, another method is through visual inspection with acetic acid wash. The rationale is that acetic acid, or vinegar, usually prepared as a 3 to 5% solution, denatures tumor-related proteins, indicated by an aceto-white discoloration of the cervix. This is most useful in regions where there are little resources, such as a pathology lab, or where patients fail to follow up after initial consultation. Remember that HPV testing or Pap smear results may take days before they come out, while the result of the acetic acid wash is immediate. Hence, early lesions are caught more promptly and treatment can be initiated earlier. Let us now take lung cancer as a special case. We now have screening for lung cancer with low-dose CT scan, and it's available, but is not really applicable for the average risk patient or patients from the general population. The greatest benefit is seen in high-risk populations, meaning those who are aged 55 to 74 years old, those with a 30-pack years smoking history or more, and former smokers who have quit within the last 15 years. Relative reduction in lung cancer-specific mortality was found to be around 16%. The use of chest X-ray and or sputum cytology for lung cancer screening does not reduce mortality from lung cancer in the general population or in ever smokers. So an X-ray or cytology is not recommended. So there you have it, a brief summary of screening methods for the common screenable cancers afflicting Filipinos. Let's just review what I've discussed so far. I discussed the burden of cancer globally and locally. I then talked about the importance of reduction of cancer incidence and mortality as the end goals of cancer screening, and that screening can be effectively performed in most cancers, or 3 of the common cancers in the Philippines. Despite the benefits of early detection, the absence of national policies or cancer prevention supported by legislation will make it hard for us to expect a significant drop in cancer mortality in the Philippines. I hope that it will change with the implementation of the Cancer Control Act. So what happens now when screening is not performed and cancer is diagnosed at a later stage? Just to let you know, we can still do something about it since there is such a thing called tertiary prevention. And it is simply equivalent to actual treatment of cancer. What are we preventing here? For a patient has been operated on already, we can prevent the recurrence of cancer by administering adjuvant treatments in the form of chemo, or in the case of breast cancer, we can also use hormonal or targeted therapies. For a patient who has metastatic cancer, we can prevent the progression of cancer and the development of complications due to tumor spread. So in a way, there is still some preventive measures. Let me just give you a general overview of the current management of cancers I've discussed. So starting off with breast cancer, when caught early, breast cancer is basically treated with surgery in the form of modified radical mastectomy or breast-conserving surgery. Mastectomy has been the standard of care in the past, but now it has been found that breast-conserving surgery or BCS can actually lead to similar outcomes as mastectomy with less complications. There are some caveats to this though. The proper selection of patients for BCS should be done, otherwise you end up with tumor recurrences and eventual mastectomy. Also, BCS should always be followed by radiotherapy as an adjuvant local control measure. Usually, adjuvant systemic treatment is given post-operatively to further reduce the risk of recurrence and improve survival. This is given in the form of chemo, plus or minus hormonal therapy, plus or minus targeted therapy. And how do we do this? We try to individualize treatment by analyzing the biology of the cancer through immunohistochemical staining for markers. Heard about estrogen receptors, progesterone receptors, and the HER2, or the human epidermal growth factor receptor. If the patient is ER or PR positive, she can receive hormonal therapy. If negative, hormonal therapy will be practically ineffective. And then there's trastuzumab, an anti-HER2 antibody which targets the HER2 protein of HER2-positive cancer cells. It's usually given for a year for patients who have had successful resection of their breast cancer. Now, in the metastatic setting, surgery and radiotherapy have very limited roles. Systemic agents like chemo, hormonal therapy, and HER2-targeted therapies have a greater role to play in delaying progression and in improving survival. But they are just palliative, since the disease is no longer curable at this stage. There are also newer agents that can be combined with these drugs, but suffice it to say that systemic treatments are the main therapies for stage 4 patients. When we talk about colorectal cancer, we are actually referring to two distinct diseases that are actually clumped together. Rectal cancer, as opposed to colon cancer, usually has a poor prognosis, but in stages 1 or 2, it can still be cured with surgery and sometimes radiotherapy or chemo radiation. On the other hand, surgery is usually sufficient for stages 1 and 2 of colon cancer. For more advanced but non-metastatic disease, adjuvant chemotherapy is often required to effectively reduce the risk of recurrence. And in the metastatic setting, just like in breast, systemic treatments play a greater role in the management of colorectal cancer. These may be combined with targeted agents against EGFR or PGF in order to improve survival or delay progression. And among metastatic colorectal patients with a high microsatellite instability, immunotherapy significantly improves outcomes. So nowadays, personalizing treatment has come into play depending on the patient's tumor biology and molecular characteristics. But unlike in breast, roughly 1/5 of patients with stage 4 disease can still be candidates for curative resection, especially if metastasis is limited to just one organ and deemed resectable. So it's very important that the multidisciplinary team is crucial. It's very important that an MDT, a multidisciplinary team, determines this, meaning the resectability or curability of a stage 4 disease. And that is why it is encouraged in tertiary hospitals. Moving on to cervical cancer, it's usually managed with either surgery or radiotherapy depending on the extent of tumor. For more advanced cases, concurrent chemo-RT or more radical surgery or even systemic chemotherapy would be more important in controlling the spread of disease and in palliating symptoms to provide a better quality of life. Lung cancers are seldom resectable upon diagnosis because they are usually advanced when detected. Except for a few early cases, lung cancer is usually managed with systemic treatments, and systemic treatments will depend on the histology of the tumor and the driver mutations present in the tumor. So gone are the days now when palliative chemo is the only option for metastatic lung cancer. I'm happy to let you know that we are now more able to personalize treatment with the aid of biomarkers. So depending on what markers are present, we can now offer either oral targeted therapies, immunotherapy, or the conventional chemotherapy. And studies have shown that when patients are given these treatments that are appropriate for the type of tumor, prognosis and clinical outcomes. But given the complicated management of all these different cancers, suffice it to say that these treatments are mainly based on well-evaluated studies that have been consolidated into guidelines. And in the Philippines, we still lack local guidelines, so we generally follow the NCCN guidelines, which you can access for free. And you can see the address on the slide here. So just to summarize these treatments, what I can say is that the management of cancer has now become more personalized because of discoveries of biologic or molecular markers that can predict prognosis and the response to treatment to specific drugs. This has allowed longer survival among cancer patients and to some extent an improvement in their quality of life compared to decades ago. However, you need to bear in mind that the newer drugs that have been developed are quite expensive. And so in our country, despite the availability of newer drugs that improve outcomes, it would be much better to focus on prevention in order to reduce the cost of cancer care. But just to demonstrate as I conclude this talk, let me just show you the case of colon and rectal cancers. As I mentioned earlier, surgery usually will suffice for the treatment of early stage colon cancer. The cost of treatment ranges from around 60 to 100,000. And the same is true for stage 1 rectal cancer, with the cost of surgery ranging from 80 to 150,000. With the addition of RT, specifically in stage 2 rectal cancer, this brings up the cost to around 220,000. In more advanced cases of colorectal cancer, chemotherapy is needed for more effective control of cancer. And in the metastatic setting, targeted therapies are usually added to standard treatment, thereby jacking up the cost of treatment to as much as 670,000. Take note that these are rather conservative estimates of the cost of treatment, based on GH and some private hospitals that cater to Class C. Compare the prices with the cost of screening. The gold standard colonoscopy can cost as much as 30,000 per procedure. But because it is recommended to be repeated usually after 5 years or 10 years, the effective cost per year is only around 3,000 per year. If you choose stool exams and screening tests, the cost is reduced to about half of the annual amount that you would theoretically have to spend per colonoscopy. And if you think about it, how much does an average office worker have to spend per coffee if he or she regularly buys from Starbucks coffee in a month? I'm sure in a year's time, he or she would have to spend much more than the cost of a stool exam. And for individuals who prefer to keep up with the latest technology in terms of cell phone or other gadgets, how much would you spend for a cell phone? It's definitely much more expensive than what you would have to spend per year for a colonoscopy. So I think the behavior of individuals need to be reviewed in order to promote a more health-seeking behavior. Putting the tables for screening and for treatment side by side, it's clear now that screening or early detection is the way to go if you want to save lives and save money as well. And what's more, the prognosis and the chance of cure are much better with screening. So when people ask me, why isn't there a cure for cancer yet, or has a cure for cancer already been discovered? My take on these questions is this: there are modern treatments available for cancer, but they cannot always guarantee cure. What is more important is to focus on prevention because it has been found to significantly bring down the number of cancer deaths. So although it's cliche, let me end by emphasizing this quote from Benjamin Franklin: "An ounce of prevention is worth a pound of cure." Thank you.
Thank you for your insightful lecture, Dr. Sacdalan. We now have 152 logged in through live streaming and 182 participants through Facebook Live. We would like to thank today's sponsor, Merck Sharp & Dome, MSD. We will now allow our webinar viewers to ask questions from our speaker. Our first question is from Katrina Morales. For prostate cancer, is it still advisable to do the PSA test and rectal exam? At what age should they be done?
Okay. For prostate cancer, PSA testing has been controversial because, as I mentioned in my talk, sometimes prostate cancers may be detected by an elevated PSA, but they may actually not be that aggressive and may not really require treatment. So it has been taken out as a hard recommendation to do. But if you want to do it, you may. Although it entails that risk of overdiagnosis, as I mentioned earlier. And if you are to do it, the recommendation in the past is to start annual PSA testing at age 50. Doing a rectal exam alone to check for prostate CA is not that sensitive.
Okay. Our next question is, can we use breast ultrasound instead of instead as a screening tool for breast cancer identification?
Well, the sensitivity of a breast ultrasound is not as good as mammography. Mammograms are more capable of detecting smaller lesions that may be suspicious for cancer, including small calcifications in the breast, whereas a breast ultrasound is not. The level of the sensitivity of a breast ultrasound is that it can detect nodules or masses as small as 1 cm, which is quite big already. Medyo late na yun eh. Usually, microcalcifications, which are smaller than that, are more easily detected by a mammogram. So, ultrasound is not really recommended.
Okay. We have a question here. Is there a role of supplements in cancer management?
Okay. Supplements have not really been, supplements in general have not been proven to effectively kill cancer cells. Contrary to what many advertisers would say, maybe claims of cytotoxicity of these supplements may be based on lab results, meaning in vitro studies, but not really in human studies. So, in the absence of clinical trials using these supplements, I really cannot say that supplements have a major role in cancer management. If ever they do, maybe it would really in symptom control or symptom management, making the patients feel better as they cope with the side effects of chemotherapy. There are limited studies to show that supplements can help in relieving nausea and vomiting and other side effects.
Our next question is, there are many Filipinos younger than 50 who develop colorectal cancer. What's the current age cutoff where routine colonoscopy is recommended? And if negative, how often should they be done?
The current recommendation now is to start screening at age 45. In the past, it was 50, but given that there's an increasing incidence of colorectal cancer in the young, I think that is the reason why some recommending bodies have lowered the age to 45. And if once it's done and it's negative, then you can repeat it after 10 years.
Our next question is, if you have a strong family history of breast cancer, as early as what age should screening be done?
Okay. This is regarding patients with a higher risk of developing breast cancer now. So this is different from what I discussed, which is for average risk patients. If you are at higher risk of developing breast cancer, it's advisable to start screening earlier. Usually, a rule of thumb is to know at what age the nearest relative with breast cancer developed the disease. And then you subtract 10 from the age. So, for example, a woman's mother had breast cancer at age 50. At age 45. Usually, hereditary cancers kasi per earlier. You subtract 10 from 45. So, at age 35, that's the age at which you should start screening. So, this is for high-risk patients.
Our next question is, how long should one abstain from meat and iron supplement prior to FOB?
Usually, we advise 3 days of abstinence from meat before we do an FOB.
Another question. So, for example, given like a 50-year-old male or a 50-year-old female with no history of familial history of cancer, what tests would you recommend for these two patients, the male and the female?
So, average risk patients.
Average risk patients.
So, for example, yung mga annual people, they want to screen for cancer, I would usually recommend for women mammography, doing a Pap Smear, and colonoscopy. For men, of course, is the colonoscopy. But that's based on generalities lang. Of course, it's very important to take note of the patient's history and note for any clues that would give you an idea that this patient may be at risk for other cancers. Like if the patient is a heavy smoker, might want to consider doing low-dose CT scans if this patient is much older. it's 55 and above.
What about tumor markers? Do you still request that?
Blood tumor markers are unfortunately not that sensitive, and they're not even specific for screening cancer. So we don't usually recommend that. Tumor markers are usually very helpful when patients have already been diagnosed with cancer and are undergoing treatment. So the use of tumor markers is in monitoring response to treatment, not in picking up cancers as a screen. Because it can lead to a lot of false positives or false negatives. And it results to a lot of anxiety as well.
Okay, we'd like to encourage everyone to send their questions to Facebook or live streaming. Our next question is, what is the stand of the Cancer Society on alternative medicine claiming to cure cancer? Some alternative practitioners are DOH accredited.
Okay. For some supplements that are being promoted as cancer treatment, our stand there is to say that it really does not. There's no evidence to show that it does cure cancer or cause cancer cells to die, unless there are studies to prove that. So we are against the promotion of these supplements as cancer treatment. The issue about accreditation by DOH or FDA, I think that accreditation is accreditation as a supplement, as I believe. No? So it sometimes there is this wrong notion that if you have that label of being accredited by FDA as a supplement, you can promote it as treatment. But that's totally different. So people have to know the difference.
Our next question is, if biopsy findings are benign, how often should screening be done post-mass excision for an 18-year-old female with ovarian mass? Consultation.
I think for this case, I think there are a lot more details that we need to look into. So I think it's better to consult na lang a gynecologist for that. No? Kasi there are many other factors that we need to consider.
Okay. Next question is, why do some hospitals offer tandem mammogram breast ultrasound in women wellness packages? So I guess she's asking if this is good for screening, doing it in tandem, a mammogram and breast ultrasound.
There are some cases wherein mammogram may give an equivocal result. Sometimes it would recommend additional diagnostic tests like ultrasound. If in cases wherein the breasts are dense, that it cannot be fully evaluated, or if there are other lesions that may need verification by another imaging test, like ultrasound. So to increase the sensitivity of the mammogram, sometimes we request a breast ultrasound. But it's usually, we always start with the mammogram first. And if findings are not that definite, then we can request for an ultrasound. Sometimes, siguro for ease of on the part of the patient, para isang testing na lang, we do it at the same time. But this usually happens, I think, for younger women because they have denser breasts. It's more fat tissue that obscures the sensitivity of the bubble.
Okay. Our next question is, what is the role of stem cell therapy for certain cancers?
As of now, for solid tumors, there is no role for stem cell therapy. Stem cell treatments are more applicable for hematologic cancers, and this is in the form of bone marrow transplant. They get stem cells from bone marrow tissue and use it to replace the bone marrow function of patients with tumors or lymphomas.
I think we tackled this briefly. How sensitive is CEA as a tumor marker for OFWs as part of their pre-employment exam? So I think a lot of people they get this test as part of a package.
Yeah, fortunately, it's not sensitive. So if you get if you do a CEA with no symptoms, no no suspicion of cancer, it is not helpful. So if it's negative, it doesn't mean that rule out cancer. If it's positive, meaning it's elevated, it doesn't always mean that it's due to the presence of cancer. CEA can be elevated in several conditions, several malignant and benign conditions as well. The mere smoking can actually increase your CEA level. So again, it's not that up.
Okay. We have another here asking for the frequency of doing mammography and sonomammogram if it's negative. How often should it be repeated?
As I said, for an average risk patient, you can do it yearly or every 2 years. Oh, sorry. I think the question is for strong family history.
Strong family history.
Still annual, every 1 to 2 years. Of course, doing it annually might be more recommended if you have a high risk. If you have a high family history, a strong family history rather, and in some cases, sometimes an MRI of the breast may be helpful also. So this is for high risk patients.
Is there any updates or recommended tests for early detection of pancreatic cancer?
Fortunately, they're not right now. So there are no recommended tests that we can do to detect pancreatic cancer. That's the problem with these cancers. When patients develop symptoms, it's usually later. Doing CT scans or ultrasounds have not yet been found to be cost-effective screen.
So we also had a question I think earlier about brain cancer. So I guess for these lesser common cancers, we don't have a formal way of screening for them. Is that correct?
As of now, there's no evidence for an effective screening tool for these less common cancers.
Okay. Next question is there a recommended screening for a patient chronically exposed to secondhand smoke?
Right now, there are no recommendations, but as of now, I think if you are exposed to smoke, I think you would still be considered as part of the average risk patient. So the recommendations I mentioned would still apply.
What about the lifestyle changes? You mentioned alcohol. Are there other things that people can do in order to prevent cancer?
Yeah, this would fall under primary prevention. So lifestyle modification would entail avoidance of smoking. That's number one, because it's a very known. It's a well-known risk factor. Alcohol in moderation. Increased or improved physical activity. Staying active has been shown in several papers to help reduce the risk of developing cancer. And watching your weight. So avoid trying to stay within your ideal body weight. Avoiding overweight or obesity can also help. Because there are a lot of obesity-related cancers nowadays.
Do you have any more questions? So, again, we have Dr. Sacdalan who's discussing the big C, cancer screening, early detection, and updates. And so, this is a question. So, tumor marker tests in health packages screening offered by leading hospitals are useless? Question mark.
I would say so. Yeah.
Okay. If a patient does not want to undergo a colonoscopy, are there biomarkers that can be requested for early detection? So is there really a substitute for colonoscopy?
As I mentioned, you can use stool exams as an alternative. It's less sensitive, But you know, any form of screening is better than no screening at all. So even if a patient would refuse colonoscopy because of either the cost or the hassle of going to a bowel prep, I think it's better that this patient have a stool exam.
What about those people who swallow those small cameras?
Oh, that's another alternative to colonoscopy. It's a less invasive procedure called capsule endoscopy. Yes, you can do that. The only disadvantage lang of this procedure is that if there's a lesion found, for example, there's a suspicious polyp found in the colon, this patient would still have to undergo the real colonoscopy in order to biopsy that polyp or that lesion.
All right. Next question. Is it true that frequent eating of grilled food can increase risk of cancer?
Well, yeah, they say that the charred portions of meat can expose you to more free radicals. And, I guess yes, that may increase your risk of developing stomach or other GI cancers. And that is assuming that you do that for every meal or you do it every day. Of course, if it's once in a while, I don't think your risk actually significantly increases because your body has this tendency to heal itself once exposed to
Okay, pwede pa tayong mag-barbecue.
Oh, it's allowed naman once in a while. Again, everything should be in moderation.
Okay. Is there a correlation between untreated childhood pharyngitis to nasopharyngeal cancer?
I don't think there's evidence that chronic pharyngitis will nasopharyngeal cancer. Although there are theories that say that chronic inflammation, not necessarily the form of pharyngitis, may predispose to the development of cancer. But I think this is subject to more studies.
What are the obesity-related cancers?
Okay, so the more common ones would be breast cancer, colorectal cancer. There's some papers that say that prostate cancer is also related to overweight and obesity because increase in adipocytes can lead to release of the development and release of hormones that can affect these hormone controlled cancers, prostate.
What about some infections are linked to cancers like HPV and cervical cancers? Or are there any others?
HPV is associated not only with cervical cancer but also with anal cancers and oropharyngeal cancers. HBV, hepatitis B virus, is linked to liver cancer. So these are some of the more common viral infections, but there are also cancers that are linked with Epstein-Barr virus.
So in relation to this, would you recommend vaccination for certain types of cancers?
For HPV and hepatitis B, definitely vaccination is recommended as part of primary prevention measures. For EBV, there's still no recommended vaccine.
Next question. If a parent had hepatocellular CA due to chronic hepatitis and the children have negative HBsAg, should there be any more follow-up?
If the children are negative, then I would recommend vaccination with hepatitis B. That would help prevent the risk of developing hepatocellular CA in the future.
So we have another food question. Any
my classmate ko yan.
Classmate mo yan. Maraming food question. Kilala ko to. Any recent evidence or increased risk for colorectal cancers with increased intake of processed food? So I think a lot of people are right now trying to eat healthy, be healthy. So is there evidence to support?
Yes, there's a lot of evidence now. In fact, I think the WHO released an advisory a couple of years ago that we have to avoid or minimize the intake of processed foods to avoid colorectal cancer because there's been an association with that, with intake of processed foods and development of colorectal cancer.
Okay. So, next question. Would a woman who has never been pregnant at age 40 be considered to have above average risk for breast cancer, meriting earlier screening?
Well, nulliparity is one of the risk factors for breast cancer, although I wouldn't really say that it would automatically put you at higher risk compared to the general population of women. Usually when we talk about high-risk patients, this would refer to patients with a strong family history, even those with confirmed BRCA mutations. But for those with these factors like nulliparity, late menopause, or early menarche, I think average risk pa rin yung classification.
So we have a question from the UK. How sensitive is a chest X-ray in finding lung tumors in a patient who has been coughing for 4 weeks? Some countries do this as initial testing for smokers and non-smokers.
Well, in patients who are symptomatic, meaning they've been coughing for quite some time already, it's already chronic cough kasi 4 weeks na. Chest X-ray may detect a lesion that would explain the cause of the coughing. And so, yes, I guess it could be sensitive enough to detect something if you suspect it to be either chronic lung infection like TB or a malignancy. This is different from screening. When I talk about chest X-ray as a screening test, I'm talking about doing it on patients with no symptoms. So in this case, I think an X-ray would be beneficial.
All right. Next question is, when to screen a patient for hepatocellular carcinoma and hepatitis B infected patients with negative results for HCC at diagnosis? Hep B infected patients with negative HCC. So when will you do the next screening?
Okay. I did not include this in my presentation anymore, but there are recommendations that you can do liver ultrasound every 6 to 12 months if you're diagnosed to have chronic hepatitis B. And again, this is not screening for the general population, but those at high risk, meaning those already infected with HB or with HC. So yes, you can do liver ultrasound frequently, every 6 to 12 months.
Okay. Another food question. Is it true that using microwave to prepare meals increases risk for developing cancer?
Using microwave per se, I don't think there's that much evidence to say that it will cause cancer. Probably the mixing of some chemicals with the container and the food might put you at risk. But again, these are based on very small studies. So as of now, let me just say that there's no evidence to prove that microwaving your meals will increase your risk of developing cancer.
Yeah, we probably get a lot of questions like that at the clinic. Next question is, if a patient has been resistant to hormonal treatment and then to chemo afterwards, is there any evidence support that first treatment will work again, albeit at a lesser efficacy?
Well, generally, we don't go back to initial or previous treatments if the patient already demonstrated resistance to it, because the problem with cancer is that it mutates periodically. Every now and then, change na as they proliferate and grow within the tumor. These cells can develop or acquire new mutations that will confer resistance. And so, as you treat a patient with a certain drug, and the tumor continues to grow, that means that the tumor is already developing resistance. As you shift from one treatment to another, you're actually trying to find out what drug will work or will be effective for these highly proliferative tumors. And going back to the previous treatment may not actually be beneficial or effective So as far as chemo and hormonal treatments are concerned, this may hold true. But for newer agents, we didn't discuss this in detail anymore, but for newer drugs like immunotherapies, some targeted therapies, it may work in some cases, not for all.
Okay, another question. What does a patient need to do if calcification is detected during mammography or prostatic sonogram?
These are suspicious calcifications, then this patient has to see the doctor for those with calcifications in the breast, see a surgeon maybe for a possible biopsy. Kung sa prostate naman, see a urologist.
All right. So we're running out of time. No? So we'll try to answer some of the questions later. You can just leave them on the Facebook page. Thank you again, Dr. Sacdalan, for an engaging discussion. After this session, an email containing a survey link will be sent to you. After answering the survey, your certificates will be sent. Please answer the survey so we can assess our webinar and address more of your preferences and give you materials from this session. Thank you for joining us. We would like to thank again our sponsor, MSD Philippines, for their support of this webinar. We hope to see you again in our upcoming webinar on February 13, Wednesday, 12 noon to 1 p.m. Manila time, with our speaker, Dr. Deborah David Ona, entitled Hyper 2019, Updates on Hypertension, sponsored by Servier Philippines. Please invite your colleagues to join us in this continuing weekly CME webinar series. All webinar schedules and resources will be posted at http://facebook.com/UPwebinars. You may also email us at upmedwebinars2019@gmail.com for any inquiries. On behalf of UPCM Class 1994 and the UP Medical Alumni Society, we also thank our collaborator units, UP College of Medicine Postgraduate Institute of Medicine, the UP Manila Information Management Services, IMS, and AHIN. This is Dr. Alex Tan with Dr. Dennis Sacdalan and the UP Medicine webinar team closing this session. We hope you have learned a lot from today's webinar. Join us again on February 13. Have a great week ahead. Thank you.